हाँ.
So, good morning, all of you. So today, okay, this thyroid disorder further. These all slides we have already covered. Okay, so today we will cover from Hashimoto's thyroiditis. So lymphocytic thyroiditis, it is an autoimmune condition. It is more in females than in males. Association with HLA, DR3B8 gene and Down syndrome and Turner syndromes are associated syndromes with this Hashimoto's thyroiditis. I think Hashimoto's thyroiditis we have already covered. We have to start with this decurrence viral granulomatous thyroiditis. Okay. So this decurrence viral granulomatous thyroiditis, it is a type of subacute thyroiditis, and it has association with HLA-B35 gene, and pathophysiology is it's generally self-limiting condition, and painful neck enlargement is there, and it is an inflammation, subacute thyroiditis. So there is the painful neck enlargement. The patient is concerned about more of this pain, and diagnosis raised ESR association with HLA-B35, and send definitely for biopsy or FLSC. So there is upper respiratory tract infection, which will be viral, most often, at sentinel events. And this, there is lymphocytic infiltration in the histopathological examination. There is a lymphocytic infiltration, and destruction of follicles are there. It's the functional unit. So the stored hormone release, initial hyperthyroidism is there, followed by single attack of hyperthyroidism. So gradual regeneration of follicles, and there is euthyroid state. So it is, as I told you, self-limiting condition, inflammation, subacute type of. The main clinical presentation is painful neck enlargement. Diagnosis is by raised ESR. Association is with HLA-B35 gene. So as inflammatory, the self-limiting condition management is mainly by steroids. Now, symptomatic management till euthyroid state is achieved should be there. So, as it is self-limiting, nothing more with the management part. Now, next is there is readers thyroiditis. Readers thyroiditis. So, it is fibrosing thyroiditis. Fibrosing thyroiditis. Then pathogenesis is IgG4 mediated. IgG4 mediated. The clinical features, there is diffuse and painless enlargement of the neck, diffuse and painless enlargement of the neck. Then there is a woody heart thyroid. Fibrosis, as we know, makes the tissue hard. Fibrosis in the gland as well as the tissues. Then there is hoarseness of the voice, cases with tracheal or with laryngeal nerve involvement is there. So hoarseness is there. Then diagnosis is mainly by this true cut biopsy. As it is, there is fibrosis. Yes, FNSC you can do, but the more diagnostic is true cut biopsy. Then this management, steroids should be given. Then symptomatic management should be given, and then tamoxifen as association with the Peyronie's disease or Dupuytren's contracture mainly. So tamoxifen should be. So steroid symptomatic management, tamoxifen. Okay. So as we can see, decurrence thyroiditis, renal thyroiditis, management part is not that much vast, but yes, symptomatic management should be there. Steroids as required should be there, and drugs like tamoxifen occasionally. Then come to the malignant disorders. So differentiated thyroid cancers, these are well differentiated. Papillary thyroid cancer, follicular thyroid cancers, then earthen cell cancers. So anaplastic thyroid cancers are also there. Thyroid lymphoma, medullary thyroid cancers are also there. Now TNM staging. So as there is primary tumor cannot be assessed. If primary tumor cannot be assessed, it is termed as TX. Okay, so you can't access. So there is a cross X. Then T naught or P0, no evidence of primary tumor. Okay, so TX means we are trying, but we are not getting. And once you find there is no evidence of primary tumor, it is T0. Then T1. Now here it can be classified as if tumor is less than or equal to 2 centimeter, when greatest dimension limited to the thyroid. In T1A, 1 centimeter, less than or equal to 1 centimeter, greatest dimension limited to thyroid gland. And T2A is more than 1 centimeter or more than or equal to 2 centimeter. It is greatest in its greatest dimension limited to thyroid. So this is tumor. Fluctuate less than or equal to 2 centimeter. So then T2 more than 2 centimeter but less than 4 centimeter. So 2 to 4 is the range of T2 in its greatest dimension limited to the thyroid. Then more than 4 centimeter is T3. As T2 is 2 to 4, T3 more than 4 centimeter limited to thyroid or gross extrathyroid extension invading only up to the strap muscles, the covering muscles. Okay, so more than 4 centimeter is limited to the thyroid or gross extrathyroid extension invading only up to the strap muscles. Then T3A more than 4 centimeter limited to the thyroid. Then T3B gross extrathyroid extension invading only up to the strap muscles. So T3 you can broadly remember invading only up to the strap muscles. Okay. T3A more than 4 centimeter limited to thyroid. T3B gross extra thyroid extension invading only up to the strap muscles. Then there is T4. No gross extrathyroidal extension into the major neck structures. Then T4A and T4B is there. In T4A invading subcutaneous soft tissues, larynx, trachea, esophagus, or regional lymph nodes for any tumor of any size. Then T4B, invading prevertebral fascia or encasing carotid artery or mediastinal vessel from a tumor of any size. Okay. So 4A and 4B have been classified as 4A, soft tissue larynx trachea, esophagus or regional lymph nodes for any tumor of any size, invading prevertebral fascia or encasing carotid artery or mediastinal vessels of tumor of any size 4B. So this is the TNM classification. Now nodal involvement. It's very important as far as management is concerned, surgery, and not an N1. And not is no nodal involvement. It can further classified into A and B. So one or more confirmed benign lymph nodes. B is no evidence of locoregional lymph node metastasis. A is one or more confirmed benign lymph nodes is there. B is no evidence of locoregional lymph nodes metastasis. Then N1A and N1B. N1A that's to level 6 or 7. Unilateral bilateral. It includes pretracheal, paratracheal, or prelaryngeal, or Delphian, or upper mediastinal lymph nodes. Then there is N1B, which may be unilateral, bilateral, or contralateral. You can say so. This is one side, and you are finding the lymph nodes on the other side. It is contralateral. So unilateral, same side, bilateral, both side, or the contralateral. Neck lymph nodes, which may include 1, 2, 3, 4, or 5, or retropharyngeal. Then there is metastasis. As you all know, I'm not an M1. M0 is no distant metastasis. One is distant metastasis. So this is the broadly the most acceptable TNM classification as far as thyroid is concerned. In carcinoma, first is papillary carcinoma, 80% relative incidence in primary malignant tumors of thyroid glands. You will find 80% incidence in total thyroid tumors. Most common cancer of iodine sufficient areas, and third and fourth decade of life, mainly involving the mutilated. Females more than males, risk factors, past radiation exposure to the neck tend to be more aggressive. Risk factors are past radiation exposure to the neck and tend to more aggressive. Long-standing thyroglossal cyst. These are the replicas of this thyroglossal cyst is benign. Is the non-malignant condition, but it may long-standing thyroid cyst may lead to papillary carcinoma. Then genetics, BRAF gene, most common gene mutation is there, and RET/PTC mutation. If RET/PTC1 is there, it is less aggressive. If there is RET/PTC3, it is more aggressive with less latency period. So this is the genetics of papillary carcinoma. Then here are the clinical features, as you can correlate in the diagram also, figure also. Definitely it presents as a swelling, rare presentation as microcarcinoma or occult carcinoma as well, less than 1 centimeter in size or a cyst. You can see this swelling in the photograph. Multifocal origin, lymphocytic spread more common than hematogenous spread. Delphin lymph node, level 6 lymph nodes, then lateral aberrant thyroid, then where there is lymph node enlargement due to the metastasis with the occult primary. So lateral aberrant thyroid. Now, where there is lymph node enlargement due to metastasis with the occult primary, then hematogenous spread, most common to the lungs, as you all know. Hematogenous spread, most common to the lungs. Now, diagnosis of this papillary carcinoma, and I told you FNAC is always a gold standard, or if it is not conclusive, then you can go for crooked biopsies. So FNAC, you will see orphan any eye nuclei. Here in the diagram, in the picture, Figure you can see fine needle aspiration of thyroid gas, which allows determination of the individual cellular morphology. You can see clearly cells in this aspirate demonstrate intranuclear grooving and ground glass cytoplasmic inclusions. Ground glass cytoplasmic inclusions are clearly seen in this picture. Okay. Long arrow. Okay. Then this inclusion, cytoplasmic inclusions, so called this orphan NEIs. Orphan NEIs. Okay. It looks like this. These cellular features confirm the diagnosis of papillary carcinoma of the thyroid. So this way you can diagnose a papillary carcinoma of the thyroid. So orphan NEI nucleate now, nuclear grouping, Samoma bodies, foci of dystrophic calcification, is known as Samoma body. Then as this carcinoma, raised thyroid stimulating hormone. The raised level of the TSH is there. Now, cold nodule in radioisotope scan. You will see a cold, there is a hot nodule and there is a cold nodule. So you will find a cold nodule in radioisotope scan. Then plain X-ray neck, you will find fine calcifications, and USG neck, you will find non-palpable nodes and lymph nodes. So, and in if it is not diagnostic or if you want to stage that tumor, if USG is not diagnostic, then you can go for the MRI. But here it is written that MRI in some cases, but I think that you should always done it. It is better for surgeon. Now the management part, surgery is the mainstay. If there is T3, T4 disease, prophylactic level 6 clearance should be. If there is T3 and T4 disease, prophylactic level 6 is done. Then after surgery, if there is presence of residual disease or metastasis, full body hiding scan is done. Okay, so here is a flow chart. Surgery, if patient is less than 40 or between 40 to 45 years, tumor size is less than 2 centimeter. If it is unifocal, if there is no lymph node invasion, if there is no metastasis, all of the criteria should fulfill, then hemothyroidectomy should be done. Again, if the patient is between 40 to 45 years, tumor size more less than 2 centimeter, if it is unifocal, no lymph node invasions there, no metastasis there, if these criteria are fulfilled, then hemithyroidectomy should be done. If tumor in thyroid, even if one criteria doesn't match, then total thyroidectomy. If level 6 involved, then total thyroidectomy with central neck dissection should be done, or level 6 plus the lymph node enlargement, total thyroidectomy, central lymph node dissection, and there is the regional lymph node dissection, which may be bilateral or unilateral. Okay, so if there is metastasis further, you can go for bilateral, lateral, metastatic regional lymph node dissection. So this is the management part. Now for further management, requirements for radioiodine scan, omit thyroxine for 4 to 6 weeks after surgery. Recombinant thyroid stimulating hormone injection can be used 2 injections for 2 days. If residual disease present, then radioiodine ablation should be done with iodine 131. If there is no residual disease or metastasis, regular follow-up advised. 6 monthly USG NAC and serum thyroglobulin level should be done. Then TSH suppression is continued. During L-thyroxine, so TSH reaches to the lower limit of normal, then thyroglobulin more than 2 gram per ml. This serum thyroglobulin more than 2 gram per ml will suspect recurrence and repeat whole body scan. So this follow-up is important. Then patients with lymph node and extracapsular metastasis, single dose of radio immunization is required. Patients is with lymph node and extracapsular metastasis is there. So this radioiodine ablation is required, single dose radioiodine ablation. Then if tumor resistant to this radioiodine ablation, then external beam radiation is the next best option. In prognosis, the best prognosis of all thyroid malignancies, indolent cancer, one can say patient will attend the onco surgeon's funeral. Then there is a Lindsay tumor, which is a follicular variant of papillary thyroid carcinoma. There is Lindsay tumor. So here is the follicular carcinoma. Next, 10% relative incidence in primary malignancy of all thyroid glands, most commonly seen in iodine deficient areas. That was seen in iodine sufficient areas. It is most commonly follicular carcinoma seen in iodine deficient areas. Definitely the risk factors: long-standing multinodular goiter, then genetics, upregulations of miRNA 197 and 346 upregulations, then PTEN gene, then BAX gene. So here is the genetics. Now the clinical features presents as thyroid swelling, obviously, tracheal compression, infiltration, and stridor. This is the most common percentage. Tracheal compression, infiltration, and stridor. Hematogenous spread more common than lymphatic spread. Hematogenous spread more common than lymphatic spread. Hematogenous spread mostly to the bones, pulsatile bony metastasis, skull, long bones, and ribs. This hematogenous spread mostly to the bones, pulsatile bony metastasis, skull, bone, long bones, and ribs. And lymphatic spreads to the level 6 nodes, only observed in 10% of the cases. These are broadly the clinical features. Main is the tracheal compression and stride. This diagnosis is by FNSE, then inconclusive or capsular angial invasion, inconclusive as capsular invasion of follicular carcinoma cannot be visualized and reported as follicular neoplasm. Now, hemithyroidectomy is done and then frozen section is used for final diagnosis. Now, USG next should be done, chest X-ray, X-ray skull are the other investigations. So, main history of the treatment is FNSC, and but it is invasive and also at the same time non-invasive investigations like USG next should be done. So, here is the diagnosis, FNSC conclusive or I told you capsular angial invasion of follicular carcinoma cannot be visualized, reported as follicular neoplasm. Hemithyroidectomy is done, and then frozen section is used for the final diagnosis. Obviously, the frozen section is not available everywhere. You can go for preoperative MRI. Then USG neck, X-ray chest, X-ray skull. These are some other investigations. Here is a flow chart. The patient is 40 to 45 years, tumor size less than 2 centimeters, unifocal, no lymph node, invasion. If there is no metastasis, then all of the criteria fulfilled. If these criteria fulfilled, then again hemithyroidectomy. If tumor in thyroid, even if one criteria not met, then total thyroidectomy. If level 6 involved, then total thyroidectomy with central lymph node dissection or level 6 plus other lymph node enlargement. If there is there, if it is there, total thyroidectomy, central lymph node dissection, metastatic regional lymph node dissection, and it can be bilateral or unilateral. So after making this diagnosis, is the flow chart, surgery, management part, surgical principles, post-operative period, and follow-up at the same time. Then prognosis slightly bad as compared to the papillary carcinoma. The next is the Hurdle cell cancer. Earlier, it was thought to be a variant of follicular thyroid carcinoma, more aggressively than follicular carcinoma. Hurdle cell cancer is more aggressive than follicular carcinoma in association with hematogenesis spread. In association with hematogenesis spread, lymph node involvement is more common as compared to the follicular carcinoma. In association with then resistant to this ablation, then detected ablation, then thyroglobulin secreting tumor. The diagnosis FNSC, abundant oxygen cells. These are specific Ashkenazi flare cells, abundant oxygen cells. Then management is same as papillary thyroid carcinoma and follicular thyroid carcinoma. Poor prognosis then after follicular thyroid carcinoma. So we will manage same as papillary carcinoma or follicular carcinoma. Prognosis is poor then. So next is this chart for the prognostic factor. It is Mayo edges criteria. You can see the edges criteria: age, young is good, more than 50 years, bad prognosis. G for grade, pathologic. E for extent of tumor. S for size, less than 4 centimeters, has better prognosis. Then there is Laheg M's criteria: AMES, age, metastasis, extent of tumor, and size. Then my own message criteria is there: MSCIS. Then metastasis, age, C for completeness of resection, I for invasion, and S for the size. So these are some prognostic factors. Then there is anaplastic thyroid carcinoma thyroid. It's the least common thyroid carcinoma, fifth to seventh decade of life. Then genetics P53 mutation, miRNA 17 to 92 upregulated. Beta technique mutation should be defined. Then clinical features: rapidly progressive thyroid swelling, local invasion is there, the regional lymph nodes, there is hoarseness of voice, trachea, stridor, listener should be there. Very hard swelling, is very hard swelling. when distant metastasis most commonly to the lungs. The diagnosis you can do with fine needle respiration cytometry. It is diagnostic, gold standard that I told you, FNSC, thyroid swelling. If inconclusive, fluid biopsy is done, as in all cases of thyroid malignancies. Then staging is same for all thyroid carcinoma. Here is the management. If tumor restricted to thyroid, then aggressive surgery, total thyroidectomy, central lymph node dissection, metastatic lymph node dissection. If beyond thyroid, only palliative surgery to relieve respiratory symptoms, trachea, stomachectomy, then external beam radiotherapy. In metastasis, chemotherapy is used. These are the drugs, dabrafenib, then it is tyrosine kinase inhibitor, and metastatic anaplastic cancers, then doxorubicin, adriamycin, which is topoisomerase 2 inhibitor. So here is the prognosis. Worst prognosis of all thyroid cancer. Now the condition thyroid lymphoma. The most common incidence is the 5th to 7th decade of life. So thyroid lymphoma generally occurs in the more age group, means not middle aged. Then non-Hodgkin's B cell type, there is diffuse large B cell, small blue cell. Then clinical features, thyroid swelling as you know. Then B cell symptoms, fever will be there, night sweats, and weight loss. This will give you the history of weight loss, significant weight loss. The diagnosis is by FNSC and cannot be characterized as lymphoma, but sorry to say, but in this thyroid lymphoma, more fluid biopsy is preferred as FNSC sometimes it is not diagnostic of lymphoma, but yes, you can first go with FNSC followed by fluid biopsy. Then management part, chemotherapy, that is the regime, RCHOP, rituximab, monoclonal antibody for CD20, then C for cyclophosphamide, then hydroxydeonorobicin, then after this hydroxydeonorobicin, oncovin, then vincristine, and prednisone, followed by radiotherapy. So, in cases with residual disease after chemotherapy and radiotherapy or in recurrence, surgery is taken. Again, I repeat, in cases with residual disease after chemotherapy and radiotherapy or recurrence, surgery is taken. Now, medullary carcinoma of the thyroid. Here, the tumor of parafollicular cells, C cells, calcitonin, either its tumor marker types, sporadic, more common, familial, it's associated with man-2 syndrome. It's most common and most aggressive in man-2B syndrome. Then, younger age, multicentric pentagastric stimulation to see calcitonin. And see calcitonin rises or not. So penta estimation test. Now here are the clinical features. Again, as in all thyroid cases, thyroid swelling, diarrhea due to serotonin, then flushing due to histamine, then Cushing's features due to ACTH, then multifocal, both lymphatic spread and mitogenous spread to level 6, and most commonly to liver spread. Then it is the aggressive tumor. Then diagnosis, USG neck, FNSE, amyloid-rich stoma with dispersed malignant cells, and sorry for the interruption. So sorry for the interruption. Diagnosis, USG neck, then FNSE, amyloid-rich stroma with dispersed malignant cells and C cell hyperplasia. Then serum calcitonin level should be more than 100. Then anesthesia suggests medullary carcinoma. Then raised carcinoembryonic antigen. Raised carcinoembryonic antigen. So this is the diagnostic features. Now this management, surgery is the main therapeutic modality. If lesion restricted to thyroid, then protothyroidectomy with central lymph node dissection. Lesion in thyroid with level 6 lymph node involvement, then protothyroidectomy with central lymph node dissection with metastatic regional lymph node dissection. Then lesion in thyroid with lateral lymph node spread, then protothyroidectomy with central lymph node dissection with metastatic regional lymph node dissection. There is no role of an iodine scan, okay, or ablation in the medullary carcinoma. For metastatic medullary thyroid carcinoma, there are drugs like vandetanib, carbozantinib, and tyrosine kinase inhibitors. These are the tyrosine kinase inhibitors. Then palliative surgery is required in these cases. Then always better to rule out pheochromocytoma before operating for medullary thyroid carcinoma, as there is very high rate of this mortality of this patient. So it is better to rule out the pheochromocytoma. Now there are some syndromes associated with thyroid malignancies. We can discuss it in short. Familial adenosis polyposis, associated gene APC, then APC gene mutation papillary thyroid carcinoma, then Gardner syndrome associated with follicular thyroid carcinoma, then Werner syndrome, then WRN1 gene is there associated with FTC, follicular thyroid carcinoma, papillary thyroid carcinoma, and Hurton cell carcinoma. Then MEN2B mutation, RUT oncogene, then medullary thyroid carcinoma association, then Cowden syndrome, PTEN oncogene, then GI polyps, breast carcinoma, follicular thyroid carcinoma, and papillary thyroid carcinoma. Then McQueen, Albright syndrome, fibrous dysplasia of the gland. Then Carne complex, PPRY, gene mutation, and Batman syndrome. So these are the broadly you can remember the syndromes associated with thyroid malignancies. Then there are tests for the thyroid function, the blood investigations. Definitely, you have to go for T3 and T4, serum TSH, thyroid stimulating hormone level, like free T3, T4. These are more sensitive. When there are anti-thyroid antibodies more than 25 unit per ml or titers more than 100 considered significant. Then corrected serum calcium and serum calcitonin levels. Then here is the thyroid function state in reference with TSH, T3, T3, and T4. The normal value of TSH is 0.3 to 3.3 milliliter per ml. Then 3T4 is 10 to 30 nanomole per liter. 3T3 3.5 to 7.5 unit mole per. So thyroid function test, if it is euthyroid, then all these T3, T4, and TSH, these are normal. This is euthyroid state. Obviously, before operating, we always try to make this patient always euthyroid. It's better. Then thyrotoxic state, TSH undetectable, and T3 and T4 are very high. If there is mixed CD1, then there is high TSH level. Free T4, it is low. Free T3 is also low. So mixed. Suppressive T4 therapy, undetectable TSH, and high T3 and T4. And T3 toxicity, it is low. Undetectable TSH is there, and normal T4 as it is T3 toxicity, so T3 is high. So this is simple the thyroid function state in relation with the thyroid stimulating hormone T3 and T4. Chest and thoracic inlet X-ray, detection of the retrosternal goiter, tracheal deviation, then calcification and lung mets in few cases. Now, USG neck, look at the size of tumor, number, echogenicity, solid or cystic, and again vascularity, presence of significant lymph node, then vascularity of the gland by resistive index, then and if it is 0.65 to 0.70, more than 0.7 indicates malignancy. Then malignant nodule, anarchial angiogenesis. Here you can see the graph, prevalence of thyroid nodule detected on punctation in the broken line or by ultrasound or postmortem examination, solid line. So this is the difference, major difference. Then here in some pictures you can see the CT and MRI, PET scan, routinely not indicated but reverse reserved for the assessment of the known malignancy. But as I told you, you should go for CT or MRI for operating patients who do not have malignancies. The spread of malignancy, that PET scan obscure role in management of patients with recurrent thyroid cancer. So here in the picture, you can appreciate brain thyroid. Yeah. Now there is isotope scan. So the indications, features of hyperthyroidism, low TSH, then ectopic or aberrant thyroid tissue. Then 99M technician, there is only uptake of iodine by gland. Iodine 123, more uptake and organification of iodine backline, then cold nodule, warm nodule, and hot nodule. So it is the aspect of skin. Then fine needle aspiration cytology, FNSC, investigation of choice, discrete thyroid nodule swellings, 20 gauge and 23 gauge nodule is used USG guided, yields better results and reduce results of unsatisfactory aspirates. Then there is a Bethesda category, PHY, 1 non-diagnostic, repeat ender, USG guidance is 1C, non-diagnostic, cystic follow-up, of this 2 ATP of undetermined significance and follicular lesion of undetermined significance. Then user management is repeat FNSC or lobectomy. And if it is 3 suspicious of follicular neoplasm, hemithyrectomy is done. 4 suspicious of malignancy, hemi or total thyroidectomy should be done. And 5 in malignant, so total thyroidectomy is indicated. So this is the category, its significance, and user management. Then here is the surgical management. Basically, you can see in the photograph types. If it is, there is adenoma excision, then hemithyroidectomy. It is removal of the one lateral lobe with entire isthmus. One lateral lobe with entire isthmus. You can see part removed. This right hand side part removed. The entire one lateral lobe and isthmus is removed. Here, the lobe of the opposite side is retained. So, here the dark part of the thyroid is retained. You can see in relation with the sternocleidomastoids. You can see this picture. Now, in this subtotal thyroidectomy, it is removal of the most of the both bilateral lobes, including isthmus, except the around the tissue, a tissue equal to the pulp of the little finger of thumb. So it is left. In this diagram, you can see the light part of the thyroid, it is removed, subtotal thyroidectomy, and a very small dark shown part, it is retained. You can see this picture. We are not removing the total thyroid. The part is retained. You can see in relation with the sternocleidomastoid muscle. Pulp of the finger 4 to 8 grams of the thyroid lower pole both side. The isthmus is removed in this subtotal thyroidectomy. In 4 to 8 grams of thyroid or pulp of the finger. And understood? Now, here is the Hartley dental operation. It is removal of the entire lateral lobe, isthmus, partial subtotal removal of the lateral lobe. You can see removal of one entire lateral lobe, isthmus, partial or subtotal removal of the lateral lobe. You can see light part of the thyroid gland is removed, stomach, one entire lobe, and other side 4 grams. Again, the measurement is by the pulp of the finger. You can measure out 4 grams sulfate, and stomach is also removed in this case. So this is heart-led, then fill operation. Then there is partial thyroidectomy, which is named by as Thomas. It is the removal of mobilized gland in front of the trachea, including entire stomach. Present, not commonly used. In thyroid tissue, in tracheoesophageal group, part retained is there. You can see the part removed. Lateral lobe. In relation to the scanning rhythm is right. So in many books, you can find slight difference in the grams of the way left behind in this thyroid gland, or measurement of the weight of the thyroid gland which should be left behind. But more or less standard is this. Then here is the near total thyroidectomy. Near total thyroidectomy. Now again here both lateral lobes, except small tissue in the lower corner are removed. Recurrent. It is the recurrent laryngeal nerve and parathyroid blood supply. Isthmus is entirely resected. Then tissue is retained in either one or both sides. So you can see except a small tissue in lower hole near the recurrent laryngeal nerve and parathyroids. One on both sides, 1 gram or 1 centimeter. The part removed both lateral lobes and isthmus. You can appreciate by this yellow part in this photograph. It is shown recurrent laryngeal nerve. You can see the part retained and a small parathyroid. So it is the near total thyroidectomy. Now here is the total thyroidectomy. This entire gland is removed. Entire gland is removed without retaining any tissue. So this is the sometimes in benign disorders, but the size is more, you have to do it. So both lateral lobes and isthmus, it is removed. So basically, to summarize, the surgical management, adenoma excision, then thyroid adenoma, then thyroid adenoma excision, hypothyroidectomy. It is the removal of one lateral lobe and with entire isthmus. Okay. Then subtotal thyroidectomy, removal of most of the both lateral lobes including isthmus. Okay, a small part is left to shipment to the pulp or little finger. Then there is hardly the Hills operation, removal of one entire lobe, isthmus and partial structural removal of the lateral lobe, the hardly, then Hill operation. Now again, partial thyroidectomy, known as Thomas. It is removal of a blessed gland in front of trachea, including entire isthmus. Then here is again the near thyroidectomy, both lateral lobes, excess small tissue, the lower fold are removed. Diagram, both lateral lobes and isthmus. Then total thyroidectomy. So here we summarize this all type of thyroidectomy. Now the part radical thyroidectomy, total thyroidectomy with resection of the lymph nodes involved, depending on the pathology of lesion and metastasis, the central neck dissection or modified radical neck dissection is done. So in radical thyroidectomy, total thyroidectomy with resection of lymph nodes are involved, depending on the pathology of lesion and metastasis. Central neck dissection or modified radical neck dissection is done. Then MIVAT, minimally invasive video assisted thyroidectomy. This is very common. And central incision of size 1.5 centimeter is used, avoided in larger nodules more than 3.5 centimeter and cases with thyroiditis. So minimally invasive video assisted thyroidectomy should be. Now there is laparoscopic thyroidectomy. This is most popular method nowadays. Many institutes, many big centers are doing it. Plus the laparoscopic thyroidectomy. The vision is good. You can very well appreciate the recurrent laryngeal, but it needs some expertise. The scar is less, patient compliance is good, and obviously scarless surgery patient prefer it. And laparoscopic thyroidectomy, mini incision procedures use a small 3 centimeter incision with no flap creation and minimal dissection to deliver the thyroid into the wound and then perform the pretracheal and paratracheal dissection. So for this pretracheal paratracheal, again you can do with this laparoscopy. Then total endoscopic procedures approaches also have been described by the supraclavicular, anterior chest and axillary and breast approach. So it is according to the surgeon's choice. So mini incision procedures use a small 3 centimeter incision with no flap creation and minimal dissection to deliver the thyroid into the wound and then perform the pretracheal and paratracheal dissection. Totally endoscopic approaches also have been described by the supraclavicular, anterior chest and axillary and breast approach and transoral robotic assisted thyroidectomy. Transoral robotic assisted thyroidectomy. This lower jaw. So these are the common methods for the radical thyroidectomy. Total thyroidectomy with resection of the lymph node involvement depending on pathology. Okay. Central neck dissection or modified radical neck dissection. So this is the radical thyroidectomy. Now, here are some complications, some specific complications related to the thyroid, and some in general complications of having surgery, hemorrhage. It may be due to the slipping of ligatures either of superior thyroid artery or other pedicles or of the small veins. This is very common. Then respiratory obstruction. It may be due to the hematoma or due to the laryngeal edema or due to the tracheomalacia or due to the bilateral recurrent laryngeal nerve palsy. So respiratory obstruction, the main cause is because of the hematoma. The compression effect is there because of the hematoma. If there is it is expanding hematoma, then definitely you have to go for the correct correction or the redo surgery. And if it is the localized hematomas, suppose it is if it is nothing respiratory obstruction, it may you may treat it conservatively. Or if there is laryngeal edema, then again you have to treat the patient conservatively. If uh, it is more, then you have to it may require to intubate the patient due to tracheomalacia and or due to the bilateral recurrent laryngeal nerve palsy. So this recurrent laryngeal nerve, as I show you in the photograph, it is in relation very uh, near to the thyroid gland isthmus, and the chances of its injury uh, is very high in this recurrent laryngeal nerve, and so it may cause a respiratory obstruction also. Then hypoparathyroidism. So this parathyroid glands are situated in the lower border of the thyroid gland, and the chances of injury to this to this parathyroid gland, it results in the hypoparathyroidism. If you identified that, you can say the khaki colored gland. If you remove the thyroid, you identify that khaki colored gland at its lower pole, you can re-implant that parathyroid gland into the sternocleidomastoid muscle. So this is hypoparathyroidism, and hungry bone syndrome is there. It occurs usually in patients with preoperative hyperthyroidism. They have increased bone breakdown in their hyperthyroid state when patients' thyroid hormone level drops acutely after surgery. Stimulation to break down bone is removed. The bones are now hungry for calcium, remove calcium from the plasma. So this is a mechanism, and it's a very well known mechanism. Which is hungry bone syndrome. In case if the patient is hyperparathyroidism, in the state of hyperparathyroidism in preoperative period, they have increased bone breakdown in their hyperparathyroid state when the patient's thyroid hormone level drops acutely after surgery, after removing the thyroid gland. There is a stimulus, the breakdown bone is removed. So the bones are hungry for calcium, remove calcium from the plasma. The hungry bones. Now, thyrotoxic storm can be there. These are the well-known complications. Thyroid gland surgery. Write down. You can get this hungry bone syndrome short note. Okay, so never make this blunder of hypothyroidism. It is the state of preoperative hyperthyroidism. When the thyroid at the period of preoperative hyperthyroidism, there is increased breakdown in the hyperthyroid state. The patient thyroid hormone level drops acutely after surgery. Stimulus to background bone is removed, and the bone are looking for calcium, and they remove calcium from the plasma record. Now, here is the slide showing recurrent laryngeal nerve palsy. It can be transient or permanent. Okay, so this is mandatory to examine the vocal cord before doing this thyroid surgery, so that you can appreciate if there is recurrent laryngeal nerve palsy after surgery or not. So, unilateral recurrent laryngeal nerve palsy causes median or paramedian vocal cord position. This unilateral recurrent laryngeal palsy causes median or paramedian vocal cord position, results just in change of voice. There is hoarseness of voice, requires immediate post of steroids and speech therapy. Then there is bilateral recurrent laryngeal nerve palsy. Both sides, both sides, the intrinsic muscles of larynx are paralyzed except the cricothyroids. Then unopposed actions of both cricothyroid cause vocal cord in median and paramedian position, treated with emergency tracheostomy. Lateralization of the cord by arytenoidectomy, vocal cord lateralization, cordectomy by open or laser method. Lasers are available. And sternohyoid implantation should be done for plastic. So bilateral recurrent laryngeal nerve palsy is more common in total thyroidectomy. Okay, both sides intrinsic muscle of larynx are paralyzed except the cricothyroids. Unopposed actions of the both cricothyroids causes vocal cord in median and paramedian position, treated with emergency tracheostomy. The lateralization of the cord by arytenoidectomy and vocal cord lateralization, cordectomy by open or laser methods, sternoid implantation, and thyroplasty. Then unilateral recurrent laryngeal nerve and external laryngeal nerve palsy. All muscles of larynx on one side is paralyzed. Treated with speech therapy and Teflon injection to paralyze vocal cord, and placement of muscle, cartilage implant to paralyze cord, and arthrodesis of cricoarytenoid joint. So, a unilateral recurrent laryngeal nerve palsy and external laryngeal nerve palsy, all muscles of larynx on one side is paralyzed. Treated with speech therapy, Teflon injection or paralyzed vocal cord, placement of muscle, cartilage implant to paralyze cord, arthrodesis of cricoarytenoid joint. There. Then bilateral recurrent laryngeal nerve palsy. Here, there will be total paralysis of the intrinsic muscles of the lung. Total paralysis and total laryngeal anesthesia. So treated by emergency tracheostomy, fixing epiglottis to arytenoids, the vocal cord ligation, and often by total laryngectomy. These are the some palsies, recurrent laryngeal nerve, unilateral, bilateral. Then this external laryngeal nerve palsy. Most patients do not notice any change. Then patients may present with mild hoarseness or decreased vocal stamina, treated with speech therapy. So there's external laryngeal nerve palsy. Most patients do not notice any change. Patients may present with mild hoarseness or decreased vocal stamina, treated with speech therapy. Then hypothyroidism, recurrent thyrotoxicosis, and infection. So that's all in thyroid, benign and malignant disorders. The thyroid disorders, whether it is benign or malignant, it is very common in the community. Most often, the complaints of the patients mostly are the same, like thyroid enlargement, some swelling in front of the neck, and hoarseness of voice, difficulty in deglutition, and sometimes this fever, atypical symptoms. So cosmetic, sometimes patient have cosmetic concerns. So whether once patient comes to you, always get a non-invasive investigation like ultrasound and minimally invasive investigation like FNSC. First, this is the uh, investigation you should go for. Then the mandatory T3, T4, and TSH levels. Always make your patient euthyroid before getting him operated. Okay. Then there are further genetic genes involved which you can go for further investigation. Once there is the diagnosis not confirmed with this FLSC, you can go for Rupert biopsy. Okay. For regional lymph node metastasis, you can go for if there's carcinoma, then you can go for MRI, CT scan. Okay. Accordingly to the size, to the TNM classification, there are various management. Okay. Hemothyroidectomy, near total thyroidectomy, total thyroidectomy, subtotal thyroidectomy. Okay. As I told you, there must be some gland left behind if it is subtotal, near total thyroidectomy, 4 to 8 grams of gland, or you can say that approx the pulp of the finger, the size of the pulp of the finger you can left behind. Okay, you have to take care for the recurrent laryngeal nerve. Okay, and if there is parathyroid injury, if you take out the thyroid gland, if there is parathyroid, if you identify the parathyroid, you can reimplant the parathyroid into the stenogynon muscle muscle to prevent from hypoparathyroidism. Okay, so there are various drugs which are available for chemotherapy also. Okay, you can give for radioactive ablation therapy, and then some drugs which are used for treating this hypothyroidism. Okay, there are many complications. Okay, some complications are directly related to the thyroid. Some are in general complications like hematoma in general. Hematoma may compress the trachea and cause some respiratory distress, and you can treat it conservatively. There is laryngeal edema, which can cause the respiratory distress, which again you can treat conservatively. If the hematoma is expanding, then you have to go for surgery again, or otherwise you have to treat it conservatively. Then there are other complications like recurrent laryngeal palsies. It may be unilateral, it may be bilateral. Okay, so accordingly you can treat. You can give prednisolone, steroid, post-operative steroids. Okay, not in the major doses, but in the small doses you can give. Right? Definitely, there are minimally invasive surgeries. There are there are open surgeries. Nowadays, minimally invasive surgeries are more popular. Intraoral route is there. You can enter the scopes with the breast side, axillary side. So, accordingly, with the patient choice and with the best available modalities at the center, and more importantly, with the expertise of the surgeon. Okay, so it requires expertise, requires experience to go with the minimal invasive surgery and then can proceed. So basically, that's all in the thyroid gland surgery. Okay. The next lecture we continue next time. Some more topics. Thank you.